Hello, everybody, and welcome to Hughes Clues, acute kidney disease or acute kidney injury and chronic kidney disease. My immune system has evidently taken a break for the summer, and I have yet another cold. I apologize in advance for my hacking cough. Let's talk about the kidney, and before we talk about diseased kidney, let's talk about what the kidney does do on a normal basis. And you know that its basic job is to filter blood. And as it filters blood, it results in the removal of water and waste. And major waste that the kidney normally removes and doesn't hold on to are considered to be potassium, phosphorus, blood urea nitrogen, and creatinine. What about other jobs that the kidney does that controls the metabolic functions, such as if the red blood cells are low or the tissues need extra oxygen, that will stimulate the release of erythropoietin, which will stimulate the production of red blood cells. It tells the bone marrow to do that. Kidneys are responsible for that. Controls acid base with hydrogen ions, removal of hydrogen ions, and secretion of bicarb. It regulates calcium. How does it regulate calcium? Well, for calcium to be absorbed from the foods that we eat, vitamin D has to be activated, and the kidney makes a substance that will activate vitamin D, so then therefore you can absorb calcium from the food products that you eat. Now, we do get some vitamin D from the sun, but a good portion of it has to be activated by the substance made by the kidneys. In addition, the kidney does filter water and waste, but its job is to also ensure that the substances aren't that we really need, such as glucose and proteins and red blood cells, aren't dumped. That's like dumping liquid gold into the toilet. So the kidney is there to ensure that proteins and red blood cells are not removed from the blood. We really shouldn't, and especially in this course, should not see protein or blood in the urine. What does acute kidney injury mean to you and who is at risk? Well, acute kidney injury means that the kidney injury happens suddenly and the kidney is unable to do its job. And the job that it's supposed to do is filter blood and remove water and waste. Anytime you do an exam question that anything related to the kidney, always, always, always first think remove water and wastes. Well, who's at risk for acute kidney injury? Well, I've got some statistics there that you absolutely don't need to know, but you can see that quite a few intensive care unit patients, so these are critical care patients, will develop acute kidney injury. And anybody that has additional comorbid conditions such as advancing age or cardiac disease or diabetes or hypertension is placed at a higher risk for the development of acute kidney injury. What does that mean to you, the nurse? You got to always be on the lookout for it. Let's compare the causes of the different types of acute kidney injury. And there are three different causes: acute pre-renal acute kidney injury, intrarenal acute kidney injury, and post-renal acute kidney injury. Well, just as it sounds, pre-renal means the problem occurs before the kidneys. And you know that the kidney's job is to filter blood. Therefore, to do its job, filtering blood, it must receive blood. It must have a very consistent and a normal or adequate amount of cardiac output. So anytime there is a problem in the body that results in a decreased cardiac output, you have to think this patient is at risk for acute kidney injury pre-renal. Now, some of the obvious reasons that you would have decreased cardiac output would be hypovolemia. Think about the fact that we're doing burns and trauma, and hemorrhage, but also think about diuretic overdosage. In general, the heart has to pump, so any kind of cardiogenic shock or myocardial infarction or heart failure can cause a decrease in cardiac output. And then if there's some kind of damage to the artery itself, for instance, there's some individuals that have either atherosclerosis or they're just born with a stenosis or narrowed renal artery, well then that can cause problems too. Let's talk about intrarenal AKI. This means that the damage or the reason why the kidney is not functioning to its optimal level is because there is damage in the kidney itself, and that means damage to the nephron. Now remember that the nephron is made up of the tubule and the glomerulus, so it can be either portion or both of the kidney nephron. The intrarenal damage can occur if your prerenal problem, such as a heart attack or shock states or hypovolemia or whatever the reason, if that is not fixed in a timely manner, and that timely manner is going to vary between patient to patient. Some sources say, hey, you can develop prerenal AKI in as little as 40 minutes after receiving less cardiac output. So it can occur fairly rapidly. It just depends on the individual. Notice that nephrotoxic drugs, such as just regular drugs that we give for our patient, like antibiotics, certain antibiotics, and contrast dyes. So your myocardial infarction patient who had to have a cardiac cath would get contrast dye, and that can cause nephrotoxic injury. I've got a long laundry list here. I just want to also point out myoglobin release, because we've talked about the fact that statins put a patient at risk for myoglobin release and also burns, crush injuries, and sepsis. So you can read the rest of that laundry list. SLE is systemic lupus erythematosus, an autoimmune disease. Excuse me. Postrenal. Well, postrenal to me says obstruction. In other words, it's not even a kidney problem. You have some kind of obstruction either in the ureter, urethra, or within the bladder itself. And frequently, stone formation can cause this, or in men, it can be BPH. And really, before the kidney is going to be damaged, remember that your urine is made and then it's supposed to flow down and out. So the problem, especially if there's a blockage that's high up in the ureter, well, then what will happen is you'll have this backflow of urine, not meaning that it's going backwards, but you'll have, just like our traffic scenario that I've talked about before, you'll have all this urine that's just jammed in here, and that can increase the pressure within excuse me, within the nephron. It can actually damage the tubule and the glomerulus. So it's a really long stretch, in my opinion, of getting postrenal. It doesn't happen that often. In my 35 years, I've never seen it. That doesn't mean that it doesn't happen. But I would think of the other two before I thought of postrenal. Let's do a case scenario and just kind of run through some things that you, the nurse, should be really in tune for so that you can assess and predict, or at least determine, if your patient's at risk or undergoing. We've got a 78-year-old male, second post-operative day, had a colon resection for a ruptured diverticulum. The only medical history that he has is diverticulosis. The surgery was uneventful, and he's currently NPO'd. Now let's look at his urine output for the last hour. 30 cc's, 25 cc's the previous hour. Here's your vital signs. He's on gentamicin, prophylactically for infection, and he's getting D5 half normal saline at 150 cc's an hour. So let's look at some of these assessment features and figure out if we potentially have an acute kidney injury issue. And the first question I want to address is, how much urine should he produce? Like, what would say to you, well, this is abnormal urine output or normal? And we go back to the same thing that we've learned before in our shock states, is that an 80-kilogram individual should have at minimum 0.5 mils per kilogram per hour. So that's at least 40 mils per hour. But then they even define it even further by saying that there should be at least 400 mils per day. And anytime there's less than that, then you have a suspicion of some kind of acute kidney injury. Notice that acute kidney injury is divided into three different phases: the oliguric phase and the diuretic phase. And I am not going to go over all of that because this recording would just be too lengthy, bulky, and downright boring. But I have copied and pasted the information that I've retrieved in kind of an outline form, and I've put it in the very back or the last page of your AKI CKD worksheet, so you can look at that at your leisure. But just know that the insult, in other words, the problem that caused the AKI, your oliguric phase within 1 to 7 days, because this is an acute problem. It's got to be usually somewhere in the 1 to 2 days, but I can see here by definition it's 1 to 7 days. So what classification of AKI could this patient be potentially developing? Well, there's nothing in the history that tells us that he has an obstruction. Absolutely nothing. He has no previous history of BPH, any of those, and that's prostate issues. So our first thoughts is, well, is this a pre-renal AKI or an intrarenal AKI? So let's look at each one. We've got the criteria, and that's low urine output. So it could, with that definition, be either pre-renal or intrarenal. Now, if we were thinking about pre-renal, well, what's the definition of that? Well, it's something that happened to occur before the kidney, and that's usually a diminished cardiac output from hypovolemia or dehydration. Well, when we look at his blood pressure, it is a little on the low side, but you know blood pressure is just a number, and some individuals run low. So we can't say for sure that that's the cause, but if he was hypotensive or his blood pressure was low because of a volume thing, well, what do you think his heart rate would be? Well, it would be elevated, and it's not. It's normal. So hypovolemia is probably not an issue with this individual. In addition, his fluids are running at 150 mils per hour. That's quite a decent amount of fluid. So really, by all intents and purposes, I'm not thinking that this is the low cardiac output state. Then when we look at a possibility of intrarenal AKI, what places him at risk for damaging his kidney nephron? Well, he's receiving gentamicin. That's a nephrotoxic drug. So, we've got a possible intrarenal AKI going for him right now. So let's look at his lab values. And I've got them here before you, and let's talk about the clues that indicate. Hopefully you have this presentation printed up and you can see those values. When you look at his BUN and creatinine, these are substances that the kidney directly removes. These are waste. These are both elevated. And of course, maybe you remember from patho that we said, hey, if the BUN is elevated, it could be kidney. But if the creatinine is elevated, well, then we really have to think, yeah, this is definitely, or most likely, highly likely, a kidney issue. So these are two wastes. They're elevated in the serum, in the blood. Therefore, the kidney is not doing one of its jobs. It is not removing these wastes from the blood. Notice that his sodium level is decreased, and really for the most part, sodium in the urine is not supposed to be there. We really do hang on to the majority of our sodium, and when we see sodium in the urine, that's kind of a clue that there is intrarenal AKI. The patient is dumping sodium. Also notice the specific gravity. It's low. The kidney is not doing its other job, which is to concentrate urine. It's supposed to get rid of water. It's supposed to get rid of waste. There's a specific ratio that it's supposed to be removed in. Now, if you're thinking specific gravity, not really remembering what it's all about, let's just do a sidebar and go over specific gravity. Again, all things kidney. What is it supposed to do? It's supposed to get rid of waste and water. And all specific gravity tells us is it's measured by urine. So we look at the urine and say, well, how much water is in the urine in relation to how much waste? And if you think your urine, this is normal now that we're talking about first, if you think your urine, you would say, you know what, if I drank a whole lot of water, if I had a whole gallon of water, what is your urine going to look like? Well, hopefully you said, well, it would look like this. Whatever I peed into, whatever container I peed into, I should have a lot of urine. It would fill it up to the top. This is to look like my beaker that I've peed into, and the urine should be filled to the brim because I should be peeing a whole lot of water out there, and it should be very pale because even though I'm drank, whatever, a lot of water, I still am going to get rid of some waste because, again, that's what the kidneys are supposed to do, get rid of both waste and water. So there is some waste in there, but there's a whole lot more water. So the specific gravity is going to be very dilute. It is not going to be concentrated, but it should be normal. Normal specific gravity is in the 1.000 to 1.030. I don't know if you have to memorize this number, but it's pretty easy, 1,000 to 1,030. So that's what normal specific gravity. And when it's on the low end of normal, and that says to you, hey, I've got a whole lot of dilute urine. And plus, when you look at this urine, you know, well, it's dilute. I'm peeing a lot of water. And that makes sense when I've just taken a lot of water in. Now let's talk about on the other end of the spectrum, what would your urine look like if you exercised in the Texas heat, in the sun, and you didn't bring a water bottle? Well, what would your urine look like? Well, it should look like this. Very little water. You're not going to get rid of a whole lot of water because your body says, yo, I don't have enough water. I'm going to hold on to it. But your kidney would still get rid of its normal amount of waste because, again, the kidney's job is to get rid of waste and water. So you would see very little water in relation to the normal amount of waste, and your urine would look fairly dark. So the specific gravity would be on the concentrated end of the spectrum of normal, and so that's 1.030. Go over that again if this doesn't make sense, because now we're going to talk about our patient, the patient scenario that we're talking about. The patient scenario has very little urine. We said that this individual did 25 mils per the last hour and 30 mils this hour, I think, but it's low. It's very low. It's less than what's normal. And he's receiving quite a bit of fluids. So the kidney is not removing water. This beaker should be somewhat filled. It should be at least 40 mils, if not 50 or 60. Then when you see the fact that it's very, very pale, that means that the kidney is not getting rid of waste. There is very little of the body's waste in this very little urine. So anytime your patient is not peeing a lot, it should be concentrated. It should be very concentrated. So this tells you that the kidney is not doing either of its jobs. It is not getting rid of the water that it's supposed to be, and it is not getting rid of the waste. And that is the reason why the specific gravity is low. Now lastly, in the urine, it was positive for CAS. What are CAS? Well, in every single nephron, there is a tubule, you know, the proximal, the distal, convoluted, and the loop of Henle. And those tubes are live and they have cells lining the inside of the tube. And when these cells die, when they are injured and they die, they dump down. They just peel down, kind of like if you had a sunburn on your nose, you know that that skin on your nose is going to peel. Well, when these tubular cells die, they peel off, and they're known as casts. So anytime you see casts in the urine, that says to you, I have acute tubular necrosis. And acute tubular necrosis means I have intrarenal AKI. I have cells within the nephron. Remember, glomerulus or tubule, I have cells within the nephron that are dead and they're sloughing off. That means I have intrarenal AKI. Acute tubular necrosis indicates intrarenal AKI. And again, as part of your assessment, you're going to look at that potassium level. That's another waste the kidney should be removing. And right now it's normal, but it's on the high end, so it's edging up. Let's carry on. We're concerned that this guy may be developing intrarenal AKI. And so on the next day, we come in and he's weighed first thing in the morning, like we do all of our patients, and we notice that his weight is 82 kilograms. So he was 80 kilograms yesterday. He's not eaten a thing. He has not gained 2 kilograms from eating an entire pie. Most likely what has happened is he has held on to water. And just as a reminder, 1,000 mils or 1 liter of water is 1 kilogram weight. So because this individual has held on or has gained 2 kilograms, we are thinking, you know what? He's held on to 2 liters of water. His kidney, again, is not doing its basic job. It is not getting rid of water. It is not getting rid of waste, which is what we have to always think about with all things kidney. As we progress through the day, he becomes confused and he doesn't know the date or the place, and he's complaining of nausea. What are these signs and symptoms a signal of? Well, these are signs and symptoms of uremia. So let's talk about some more definitions here. I know you're sick of this. Azotemia just simply means that we have elevated levels of waste. We have an elevated BUN and creatinine. But as I said with blood pressure, normal BUN and creatinine or even elevated BUN and creatinine is going to affect individuals differently. Sometimes they can tolerate a high level, sometimes they can't. But when an individual begins showing signs and symptoms that these wastes are toxic, and the first sign and symptom is going to be usually neurologic, because your brain is like, you know what, this uremia, this BUN, it's a waste, and this creatinine is a waste, and it really doesn't work well for me, the brain, to have these elevated. And so these individuals will be usually have neuro signs and symptoms first. In addition, other signs and symptoms of azotemia are nausea, vomiting, and diarrhea, and itching. And you might think, well, what's the story with itching? Well, your body says, wow, you've got an elevated BUN, and so I need to get rid of this, or at least try and lower it down. Kidney, you're not doing its job by getting rid of it, so I'm going to shove some of that uremia, that BUN, into the cells, and that will cause this frost to come over the cells. I should have posted a picture. um, their skin will get kind of frosty looking, kind of white and scaly, and it does cause itching. So all of those are indicators that this individual not only has a high level of waste in his blood, but it's affecting him, so that is known as uremia. This is the end of part one. I've kind of broken this up so that you guys don't just go berserk. You can keep going if you want to, or take a break before you move on to part